So Tony, this patient also, kind of with the recurrence now with the macroscopic disease, is sort of a stage 3C equivalent patient, not a true stage 3C, but a stage 3C equivalent. Now you're also head of the melanoma group in SWOG, and we have the SWOG 0008 study. Do you want to comment a little bit on that, what that study showed in terms of this setting in an adjuvant setting?
So SWOG 0008 was a study that was planned and conducted 15 years ago. And at that time, it predates all of the therapies, the majority of the active therapies that we have now. At that time, a combination of chemotherapy and cytokines, interleukin to interferon gamma, called biochemotherapy, was being used in a metastatic disease with evidence of responses that seem to be beyond what chemotherapy or cytokine therapy would do by itself, but also with little evidence that it led to long-lasting responses. That was tested in the adjuvant setting, and this study compared biochemotherapy with high-dose interferon, and the readout is that for relapse-free survival, it was superior for biochemotherapy, but for overall survival was completely the same. If it was anything else, it would have changed our standard of care, but it's biochemotherapy. There's been, that needs to be put in the context of randomized trials in metastatic disease, comparing biochemotherapy with chemotherapy alone or cytokine therapy alone, and there were a number of those trials, none of which demonstrated an improvement in overall survival. So I think our interpretation and the interpretation of the majority of practicing oncologists who see melanoma is that the benefit of biochemotherapy with probably the higher initial benefit is not long-lasting, and that may not be beneficial to patients.
Okay. So at the moment then, I understand you would not use biochemotherapy for this patient.
Yeah.
Mike, you're from MD Anderson. You used a lot of biochemotherapy at MD Anderson. Would you use this in an adjuvant setting for this patient?
No, I mean, I think, again, the randomized trial showed that although there was, again, a very notable difference in relapse-free survival, the fact that that didn't translate into a difference in overall survival, to me, is actually somewhat concerning. The question of how would that have not actually converted into a benefit in overall survival. I would note, though, again, that it is actually, to this point, the only adjuvant therapy that's been shown to be superior to interferon. And again, with the ipilimumab trial, we have to remember it was high-dose ipilimumab versus placebo, which, again, was the standard of care in Europe. So it'll be interesting, again, in the ECOG trial, having that interferon arm there as a control. But no, I think at this point, with really the data showing no impact at all on overall survival, would not recommend biochemotherapy. I think in the broader sense, you know, the care and the treatment options for patients with stage 4 melanoma has been absolutely revolutionized over the last 5 to 6 years. This is really the time where our emphasis is on enrolling patients in clinical trials for these adjuvant therapies to, again, see if we can similarly transform adjuvant therapy for earlier stages of disease.
So with that then, is there any role right now outside of a clinical trial then to give this patient an anti-PD-1 therapy?
No.
No.
No. And actually, the one question I would say is the other question in the management of a patient like this would be the role of adjuvant radiation therapy. Yeah. I don't know, at your center, would you recommend radiation therapy for this patient?
Yeah, so this patient actually, if we look at the patient, this patient would fall into a study that was done with radiation called the TROG study, which was done in New Zealand and Australia, but also had a few sites outside of there. And this patient had recurrence of their melanoma and would have met the criteria for this. Now, what the TROG study showed is that radiation done to the regional lymph node basin decreased the risk of recurrence in that basin, but had no impact on overall survival, which we would expect with radiation. I'm not surprised by that. We also know that the area of radiation makes a big difference in terms of toxicity. So at our institution, patients with head and neck melanoma, we're more likely to have a discussion with radiation and potentially consider it. Same thing with the axilla. The groin, on the other hand, I think our experience with the groin is that the risk of having infections, having lymphedema, and having adverse side effects, most of the time, those risks outweighs the potential benefits. So we have really decreased the amount of radiation that we do for the groin. Additionally, also, I think it's important to recognize, as we've said, is that if these patients were to recur, the recurrent therapies that we have for metastatic and recurrent melanoma is vastly different than it was previously. So we really have gone away from radiating the groin for that reason.
If the pathology report from surgery, and again, whether it was here or in the axilla, showed evidence of extranodal extension, would that change your recommendation at all?
Yes, so there is an indication then with so the number of lymph nodes and extranodal extension then would increase the risk of the recurrence. It's traditionally it may have changed in our decision on radiation. Even with extranodal extension in the groin, we would still be very reluctant to radiate this. In the axilla and the neck, as I said, we are we would definitely consider it and we would discuss it. But the groin, I think it's our experience has been that it can be a very difficult area because of the side effects.